Good afternoon, everyone. On behalf of Chest and Intuitive Surgical, I'd like to welcome you to the webinar presentation on robotic-assisted bronchoscopy. I'm George Chang from UCSD. Thank you for joining us today for a terrific conversation. A couple of housekeeping items before we start. Please note we have the audience on mute during the presentation. Please submit your questions on the question box on the control panel to the right of your screen. My first guest today is Dr. Eric Folk, Chief of Complex Chest Disease Center and Co-Director of Interventional Pulmonology at Mass General Hospital, Boston, Massachusetts. Dr. Folk, thank you for joining us today.
Thank you, George.
And my next guest is Dr. Sebastian Fernandez-Bucy, interventional pulmonologist at Department of Pulmonary Medicine, Mayo Clinic, Jacksonville, Florida. Dr. Fernandez-Bucy, thank you for joining us today.
Thank you, George, for the invitation. Glad to be here. Thank you.
All right, so without further ado, I'll let Dr. Folk take it away.
Thank you. Let me make sure I can control this. Sorry. Sorry. There you go. I don't have the controller for the slides. So to start my disclosures, I serve as a consultant for Boston Scientific, Olympus, Pinnacle Biologics, and I'm the global PI for Navigate, as well as the national PI for Precise. I've had advisory roles for both Auris in the past and Intuitive in the present. And hopefully you will not necessarily identify bias related to my view of these technologies that I've been lucky to work with. So when we get consulted regarding invasive thoracic lesions, we are faced with both the diagnostic methodology that we're going to use, as well as considerations regarding the performance status of the patient. We can call that the Karnofsky or the comorbidities present. Also the probability of lung cancer and the feasibility of a biopsy. The risk of complications, diagnostic yield, and obviously we use the human capital and technological capital available at our centers to determine what the best technology is to use in these cases. And the timeliness, obviously, there's an advantage to providing a very quick service to these patients who need it, because there's a significant delay both in Europe and the United States from identification of the problem to a diagnostic procedure and treatment. Regarding the diagnostic method, we focus on the location of the lesion, whether it's central or peripheral, and or mediastinal. And in the mediastinum, we use EBUS, EUS, mediastinoscopy. In the periphery, we tend to use navigation technologies, from the most basic radial EBUS to electromagnetic navigation platforms, robotic-assisted bronchoscopy, CT-guided biopsy, and finally VATS. And you can see that obviously each of these confers advantages and disadvantages. The advantage we have in the case of this technology, the robotic bronchoscopy, is that we can assess the mediastinum and the peripheral lung nodule on the same anesthetic episode. In this slide, in the first video on the left, you can see that the advantages of this catheter are that it doesn't flex or alter its position relative to the tool that you're using, but it keeps its shape and location. And when you increase the flexion of the catheter, it maintains that position regardless of the tool that you use. And this is a novel addition to the field. In the second video, you can see in action this shape-sensing catheter completely flexing to a lesion that is supra-aortic, and we are able to advance the needle that is flexible. So these are the main characteristics that make it attractive in this sense. This is the technology that we're going to be talking mostly today. So regarding the progression of navigation studies, it's important to remember that we started with flexible bronchoscopy with or without fluoroscopy. In 1998, the initial description of the radial levers as a real-time identification adjuvant technology. And in 2009, virtual bronchoscopy as an adjuvant to the actual act of bronchoscopy was described. The radiologist described it before, but in our field, it came in 2009. Regarding electromagnetic navigation systems, in 2005, the initial EMB studies came out. They were early, they were labor intensive. We called them Generation 1. And most of the studies at the time were Generation 1, driven by expert users, single center publications. I was lucky to be a fellow at the time under Dr. Gildea, Dr. Mazon, and Dr. Mehta, and I was exposed early to this technology that I found fascinating at the time. You fast forward to 2018, ORS Monarch obtains 510 clearance from the FDA. They get approved, and they do the first in-human study, and they publish it with 15 patients. At that time, they did not use the navigation technology for these 15 cases, but it was an interesting start for the technology. And in 2019, we published the study of Navigate, including 1,215 patients with the electromagnetic navigation or Super D system. Also in 2019, now I move forward to shape sensing technology. ION and Intuitive receive approval, 510K by the FDA. And the first study in humans is published by Dr. Fielding in Australia with 29 patients, where he actually, we will go more into this study, but he used his this new technology of shape sensing technology and navigation. And finally, PRECISE, which is the study that we are conducting at this time, is a pivotal study, multi-center at 6 centers with 360 patients, started enrolling in 2019. And I'm happy to say we're way over halfway with the cases. So what is really new in this next generation of navigation devices? Well, the first thing is the shape sensing technology, as I intend to show you, has different characteristics and advantages. It allows us to reach the most distal part of the lung parenchyma while keeping vision and articulation. It provides stability, precision of movement, and the ability to reach lesions without a bronchus leading to it. And finally, integration to other platforms like cone beam CT and radial levers that we call real-time technologies or real-time confirmation technologies. This diagram shows you briefly the comparison between the two available platforms. As I mentioned before, the ORS on the left is electromagnetic navigation based, continuous visualization, and the first in human study, yes, and as you in Costa Rica with 15 patients. And as you can see in the picture, there is actually a large catheter. There's a large catheter that internally has another smaller catheter that is actually able to drive into the periphery. This diagram that I'll show you more about is relative in size, but this is the outer diameter, the inner diameter, and finally the working channel that is 2.1 millimeters. In contrast, the intuitive or shape sensing technology, once you get to your point of the lesion, you remove the camera. And as I said, 30 patients in the initial study, or 29 patients by Dr. Fielding, were included in the publication. And the PRECISE study, as I mentioned before, the diameter is 3.5 millimeters, is uniform, and it has a working channel of 2.0 millimeters. And as you can see here, there's a peripheral lung nodule, and the robotic arm is reaching all the way to the catheter of the robotic arm is reaching all the way to the periphery, and you have a confirmation here with cone beam CT. So this is in regarding diameter, and the same thing I mentioned before. These images are drawn to scale, and they just show you the difference. Both platforms are different than the current standard for bronchoscopy, which has two wires, one on top, one on bottom, and you can only flex up, down, and you have to rotate your wrist. And also, they're different in that the working channel is in the center, it's not to the right of the catheter. As you can see on this image, the bronchoscope has obviously the channel on the right and a light source with two wires that pull it up and down. That is another meaningful difference. This video shows you the shape sensing technology, and it's a significant number, several hundred small sensors attached by this hair-like structure that is in the catheter, in the structure of the catheter, and it sends information that the software reads practically instantaneously about the location of each part of the catheter. It's not just the tip, it's not just the shape, but it's the shape and the location of this catheter. Here you see in this slide, you see the robotic platform of Ion, as well as the podium with a controller that allows us to control the movement of the catheter. Here you see the very flexible needle that allows us to obtain peripheral biopsies, and I would mention that this comes in 19, 21, and 23 gauge. The important thing regarding when you are able to navigate to the periphery and you can park your catheter is that the very small movements of the controller allow you to obtain biopsies that are separated less than a millimeter from each other. Because as we all know, there's heterogeneity in the content of tumor cells. You can have necrotic center or you can have a necrotic periphery, and this allows you very precisely to move. It also allows you to correct a little bit for the occurrence of body to CT CT to body divergence. In other words, where anatomically is the lesion or the nodule when you compare it to the available CT scan. In this slide, you can see how we gather the preclinical data leading to this shape sensing technology. First, benchtop testing, as you saw first on the shape sensing technology. This allows us to evaluate and develop prototypes that eventually lead to the current form. To give you an idea, the development of the robot has more than 10 years of bench testing in order to perfection something like this that is safe for human use. The second shows you the cadaveric testing, in which we implanted this small unit of color marker under special light on the wood lamp that were implanted in cadavers, and then we were able to navigate and test the ability of the system to have flexibility, precision, etc. And it also is a proof of concept before you engage into the swine model or an animal model, in which a live animal that is intubated with implanted targets, you're able to navigate into the periphery and place fiducial markers, obtain biopsies, etc. After this is done, we lead to human testing. And this is where the work of Dr. Fielding is very important. He did the first study, as I said. The primary endpoints were the feasibility and the safety of targeting lung nodules between 10 and 30 millimeters. Remember that that's the definition of a lung nodule. It has to be under 30 millimeters, and this marker is not arbitrary. It's because after 30 millimeters, we see a significant risk of a metastasis, and for that reason, it's important that we identify these nodules early and try to sample them. However, the smaller the nodules, the more likely they are to be benign. So his sample size, 29 consecutive patients. He did not choose them based on bronchus sign or absence of it, and he followed them for up to 6 months. And he made sure that all of them were after 3 generations, airway generations, so they were after the lower segments. The nodule characteristics were in average 12 millimeters by 12 by 11, 69% of them in the upper lobes, and 41% did not have a bronchus sign. The endpoint of feasibility was reached in 97%. No pneumothorax and no excessive bleeding were encountered. The diagnostic yield for malignancy was 88%, and the overall diagnostic yield was 79%. When we move forward to the PRECISE study, these are my colleagues who participated of the study. These 11 experts in the field have contributed at 60 different academic centers, and one community practice with Dr. Pritchett, who is well known to all of you as an expert in the field, and all of the sites have been activated. And the plan, in the next slide, the plan of the study is a prospective multi-center study involving the ION system, 360 patients in 6 centers, with the idea of demonstrating the clinical utility and navigation success, biopsy success, and characteristics of how we do it, the early performance, including sensitivity for malignancy, and the diagnostic yield trend. It's also important that we mention the learning curve. We're looking at learning curve and how fast we are able to adapt and adjust to the environment of this new device. It's important to mention that even though there is complete ability to use cone-beam CT as part of an adjunct to your robotic platform, we did not use it as part of the study, and the yield is independent of the cone-beam CT. The results were not used in the outcomes. So no, I don't have results of cone-beam CT plus robot at the end of the study. The target population is subjects who we consider moderate to high risk for malignant disease, up to 6 months of follow-up, and solid or semi-solid nodules between 10 millimeters and 30 millimeters. The nodules are located in the generation 4 or deeper. The subjects are also candidate for either surgery or TTNA in case the lesion is non-diagnostic, and the patients obviously have to be candidates for bronchoscopy and not have an increased risk of bleeding or a higher risk of pneumothorax. We did not use the bronchus sign for selection. It is patients as they came with or without bronchus sign. And I will show some of our experience in the cases that I showed you, as well as Dr. Fernandez-Busi. So this was my first case. As you can see, it's a left upper 29 millimeter lesion, and in this case, it did have a bronchus sign, as you can see on the corner, on the coronal cut. You can see that the segmentation is pretty impressive with the software in both these images, and you can see that in purple, you're able to paint the anatomic borders. So when you navigate all the way to the nodule, you limit the progression of your needle so you don't get to the your anatomic border, whether that's the pleura, the diaphragm, or the pericardium. You can limit the length that your needle travels. It's evident that I chose a lesion that I was going to reach, and it's obvious to you guys from the pictures that there's multiple people, including my colleague Dr. Keys, who have to help you in the beginning of this application of these new technologies. In the next slide, you will see the ability, not only from the higher segmentation and the fact that the nodule is pleural-based, but also that every time you do a biopsy, as you can see in this magenta nodule, in the virtual image here, you see that I've obtained 3 passes here, separated by just a few millimeters. And you can see that the radial EVOS conformation is one of central location. So I'm sure I am within a distance, within the nodule. These boxes tell me that the near border of the nodule is 13 millimeters away from the end of my catheter, and the distal end is 39. So this nodule has a vertical size of 26 millimeters. And it also tells you that the pleura is at 39. So it's pleural-based nodule. The next slide will show you a change in the radial EVOS. I made a millimetric change here in the magenta sphere with my controller, and now I'm tangential to the nodule. This very small change is perceptible, obviously, by the system. And now I'm 15 millimeters from the near end and 42 from the distal end. The next slide. I quickly became comfortable with the technology, and I tried this very difficult nodule on case 2. This is a very posterior pleural-based 11 millimeter nodule that you can see has a couple of airways close to it, but nothing leading to it. This is a bronchus sign negative nodule. And in the next slide, you can identify those 2 airways seem to go close, but not really to the nodule. So with my experience in navigation, I chose the upper airway, and I spend, as you can see in the next image, I spend a good 40 minutes trying to get to it, and I could not get the location right. So I finally said, okay, I'm going to use the pathway that the robot suggests. And I changed to the bottom one as the robot suggested, and it sent me, as you can see on this floor image in the bottom, it sent me inferiorly and then vertically up, and I was able to get the nodule on the first pass. You can imagine how this would be very complicated with most technologies. Next case I want to show you is this interesting case, case 9 of my experience. This patient was referred to me after a failed CT-guided biopsy attempt in the right lower lobe. As you can see, it's very close to the diaphragm. This area moves a lot, as all of you are aware, moves a lot with breathing and generates a lot of CT to body divergence. So this patient underwent an outside hospital CT-guided biopsy that you can see in this image with resulting bleeding around it, and it was non-diagnostic. So the patient was referred to, and a small pneumothorax, I should mention, you can see there a small pneumothorax. The patient was referred to my thoracic surgeon, and she was very kind to ask me to see the patient. I consented the patient, and as you can see on the next slide, we consented the patient for the study. It's a rounded right lower lobe, very close to the diaphragm, as I described before. We planned the case. There's no bronchus sign either. And we navigated, as you can see on the next slide, we navigated to it. We advanced the needle under fluoroscopy. Well, we first advanced the radial EVOS, and we got, it was difficult to penetrate it. And when we pushed, we were diverted from our route. So we tried again, and we got it in the center of it. And we had a confirmation that we were in the right place. When you look at these floor images, remember you're correcting for the angle based on what the system is recommending you do. And in the next slide, you can see that I was able to introduce the needle. And in front of my eyes, as I was activating the floor, the long nodule disappeared in front of my eyes. And I said, gee, I don't see it anymore. I don't know if it's because of atelectasis or because of the substance that was being aspirated into my needle. So I decided to place a fiducial marker to guide the surgeon in case this was a positive malignancy, that she could have some tactile reference point. And in the next slide, you will see what I was obtaining from my syringe. This mucoid brownish material that the pathologist read as non-malignant, granular, and PAS positive. The pathologist said, you're in the lesion, this is benign, but let me do final stains. So as I said before, I place a fiducial, and in the next slide, you will see the difference in the pre-op and the post-op with the presence of no pneumothorax, but also the presence of a fiducial marker that marks the location. Not satisfied with this, not completely satisfied with this benign diagnosis, and I obtained a CAT scan approximately 10 days later. And as you can see on the before and after CAT scan, the size of the lesion has reduced by 70%, and you can see my fiducial is placed inside the lung nodule. So this was a confirmation of a benign nodule that was not able to be diagnosed by CT-guided biopsy. And the next case is equally interesting. It's case 10. The patient underwent initial presentation. As you can see, this is a paravertebral lesion, right lower lobe in someone with emphysema and interstitial lung disease on March 29. A PET scan showed uptake just in that area. And she underwent, the PET scan on 4/11, she underwent a diagnostic procedure that led to the next image. It's a complication of subcutaneous emphysema, very severe. The patient was intubated and transferred to our hospital. We were able to support her and after a few days take her off the ventilator. And once I took her off the ventilator and she was awake, I was able to discuss with her the possibility of a robotic bronchoscopy. She immediately declined and said, no, I'm barely alive and I want out. I'll come back in 3 months. So I saw her 3 months later in my clinic. And as you can see in the next image, on 9/10, we repeated the CT scan. We saw the lesion to be slightly enlarged and no lymph nodes of concern. We did the robotic bronchoscopy on September 10. We obtained biopsies that were diagnostic for malignancy, and we referred the patient for a segmentectomy. I have to report that she had a segmentectomy, and she did very well, and she recovered and went home. Interestingly, you may ask why segmentectomy is because she had very limited lung function. But this proved to me that these patients actually benefit from this platform in the sense that we can provide diagnosis, staging, and quick collaboration with our colleagues in thoracic surgery with the intent of curative resection. Next slide. This is the fluoro images showing you the location of the paravertebral lesion and biopsying, first confirming with the radial EVIS and second identifying a biopsy with a peripheral needle. Next slide shows the chest x-ray after the attempted biopsy at the outside hospital with significant subcutaneous emphysema, and our chest x-ray after robotic bronchoscopy showing no complications. Next. My final case is case 15. This was done by my colleague Colleen Keys, who many of you may know. This is a patient with severe emphysema and a very peripheral FDG avid lesion. And I was impressed with her ability to reach the lesion very quickly, obtain a diagnostic biopsy with no complications. And I think this speaks to the reach of the catheter and the overall platform. Next slide. So with that, I will hand it over to my colleague, Dr. Cheng and Dr. Fernandez-Bucio.
Okay, so everyone, just a reminder, you can submit your question in the question box on the right side of your screen or the left side of the computer screen. Dr. Fernandez-Bucio, please take it away.
Thank you, George. Next slide, please. So we'll discuss current lung cancer patient pathway from diagnosis to treatment, then streamlining patient pathway through innovation, and we'll present some early cases as well. Next slide. But let me start with some general information here. We know that lung cancer is the leading cause of cancer death for both men and women in the United States, and it has caused more death than breast, prostate, colon, and liver cancer combined. Now, compared to the most common cancer, as you can see here in the graph, the lung cancer 5-year survival rate remained stagnant. Over the last 3 to 4 decades, actually, lung cancer 5-year survival rate has only improved marginally, while breast cancer, prostate, and colon survival rates have improved significantly in the same period of time. Next slide, please. We also know that lung cancer, when detected early, for example, at stage 1, A1, the survival rate is 92%, so that's pretty good. But the overall lung cancer survival rate is only 19%, and unfortunately, also large percentage of lung cancer are diagnosed as stage 4. Next slide, please. And we also know that early stage lung cancer are small in size. And in addition, and according to the Nelson trial, 70% of the nodules are located in the periphery, 1/3 of the lungs. And some nodules are concentrated in hard to reach locations too, like for example, the right upper lobe. So, this leads to the next question. Do we have the right modalities and tools to reach and biopsy these nodules? Now, look at the modalities we widely adopt today. We still need to make the choice between diagnostic yield and complication rates. We know that CT-guided needle biopsy achieves a high diagnostic yield. For example, a core needle biopsy in a nodule less than 2 centimeters will get us a 92 diagnostic yield, but that comes with a high complication rate. The overall complication, according to a recent meta-analysis, as you can see here, a fine needle aspiration was 24% and a core biopsy was 38.8%. The pneumothorax rate was up to 25%. Now, on the other hand, electromagnetic navigational bronchoscopy has been around for the last decade. And according to the Navigate study that Dr. Falls mentioned, the overall yield for all sizes is 73%, so still low compared to CT-guided. Now, the pneumothorax rate was 4.3%. Next slide, please. Now, if we compare the years 2010 and 2015, and according to Medicare data, we can see that the overall bronchoscopic biopsy represented 41% of the cases for lung nodules, and electromagnetic bronchoscopy increased from 2% to only 9%. Now, there's no doubt that CT-guided needle biopsy is still the dominant procedure for lung nodule biopsy, but this means that a good number of patients undergoing biopsy procedures with lung nodules are experiencing the associated complication of CT-guided biopsies. Next slide, please. So what can we do to address this unmet need? Next slide. Well, we can innovate. So innovation should help us, reach the nodule and provide stability and precision at the time of biopsy. Should be an easy integration system to our current practice and with low complication rate. Now, the ability to reach the nodule in the periphery of the lung and in hard-to-reach location is critical. And the stability is the key to perform a precise biopsy. So a navigation success should mean a biopsy success nowadays. We know that manual bronchoscopes relies on human hands to keep the scope stable. So biopsy tools inserted in the working channel can deflect and can move position, so it's not ideal. Now, the ability to make fine adjustment at the distal end of the catheter to perform precise biopsy is also essential. This is the articulation at the distal end of the catheter that the manual bronchoscope do not have neither. This new technology should also be easy to integrate into the existing practice like fluoroscopy, radial EVIS, cone-beam CT, etc. And of course, this innovation should provide a similar diagnostic yield than CT-guided biopsies, but of course with less complication rates. Next slide, please. Now, aside from the need to innovate, we can see and we know that the current lung cancer patient pathway is highly variable, and there's no standard approach to diagnosis and treatment. patients refer to a general practitioner. This practitioner that identifies a lung nodule can refer the patient to either an interventional radiology, a general pulmonologist, or an interventional pulmonologist. And with the different biopsies approach, the pathways can be different. And sometimes due to the limitation of diagnostic yield, patients may require multiple biopsies procedure to receive the confirmed diagnosis. So definite diagnosis is sometimes delayed due to this complicated referral pattern. Next slide, please. So you can see there the different biopsies approach and etc. So we think that a linear pathway is much desired for these patients. So innovation can probably provide us with this more linear pathway. Next paragraph. Next slide, please. This robotic-assisted bronchoscopy system is designed to try to address this key component of a peripheral lung biopsy, which is, the reach of the nodule, the stability, precision, integration needs, and hopefully with low complication rates. Next slide, please. So let's talk more about some technical details of this technology. The fiber optic shape sensing technology is the enabled technology that allows the system to achieve these mentioned capabilities. The optical fiber is embedded in the catheter wall, and that tracks the dynamic 3D position and location with a high degree of accuracy along its entire length. When you manipulate the fiber, the system can capture its real-time 3D shape and movement. You can see there on a video. Now, it has a unique property that it's immune to electromagnetic interference in the room. So that's also important, and it's a differentiation with other navigation systems. It does not require electromagnetic field to track its catheter, and the procedure does not require mapping. It is also subject to is not subject to metal interference and maintains navigational accuracy while on fluoroscopy or if you're using combing CT as well in the room. Next slide, please. Now, Ion is a fully articulated catheter, as you can see in the video. The distal 5 centimeters is robotically controlled. As Dr. Foltz mentioned, it has a 3.5 outer diameter and a 2.0 millimeter working channel. You can bend the catheter 180 degrees in all directions. And it also comes with a camera or a vision probe that is inserted in the working channel during navigation and provides real-time vision. Next slide. The fiber optic shape sensor measures the full shape of the catheter hundreds of times per second. And this provides precise location and shape information throughout the whole navigation and biopsy procedure. Combining these real-time measurements with robotic control algorithm, this allows the catheter to hold position once the target nodule is reached. So this is what provides the stability. Next slide. The catheter tip allow us to aim at small targets, even those located outside the airway. And again, as Dr. Foltz already showed the case. And we can repeatedly biopsy the same target while systematically change the same locations in the same target through fine movement. So that's the fine articulation. The shape sensor provides real-time positioning and orientation information of the catheter during the biopsy. And also this system comes with a flexible needle that is able to pass through the catheter even when position is very on tortuous airway. And after advancing the needle will come out straight. Another feature that this system has that I think is very useful is the biopsy marker feature. And this indicates multiple biopsy attempts in different positions, which is called the cloud biopsy. And so this feature can help you visualize different biopsy needle trajectories. So if you have rows in the room and you know you're marking with a number each biopsy, and you know that in the position where you did the biopsy number 3 is where you got the call for positive cells, then you will direct all your biopsies to that specific area. Next slide, please. And of course, the system should be easily integrated in our current practice. So now let's switch gear and let's talk more, next slide, to more practical issues. Let's talk about workflow and some case reviews. Next slide. So after you do, if you can click on the video, thank you. After you do the planning in the software, you have to do the registration in the patient. You first mark the main carina, and then you advance to the contralateral side of the lesion and then you go back to the same size of the lesion, and you go first to the lower lobe, and you go as distal as you can until the system will mark that lobe. You'll see that in a second, that left lower lobe in blue on your screen. Then you know that you have registered that area. Then you come back and you go to the upper lobe, and the upper lobe we like to go to the apical segment of the upper lobes. And I remember this was my second case, so you know I'm maneuvering with the robot in the different segment and subsegments, and you already feel pretty comfortable navigating in the airway, even after just a second case. Now I go to the contralateral side again, to the lower lobe first. You go as distal as you can. Now you see it's marked, and now you come to the upper lobe. You want to go to the apical segment, if possible, of the which is always possible, of the upper lobe. Tough bend there, and until it's marked, and now the registration is done. Next slide. And now I want to show you a navigation part. And actually, you know, going back, the registration took only a minute and a half. Now we're going to the navigation part. You can see in the upper part of the screen the bronchial tree, the target, marked target, and you can see a purple also line there. That's the anatomy border. You can actually mark the structures that are concerned to you. You want to make sure you avoid that, and mainly we mark the pleura, of course, or any critical vessels that are more than 5 millimeters. You can also choose to mark it. Next slide, please. So let me show you a case. 65-year-old gentleman, former smoker, with a left upper lobe nodule, 17 per 13 millimeter, hot on PET, uptake of 10, negative mediastinum on images. We decided to do robotic bronchoscopy to sample left upper lobe nodule and EBUS for mediastinum staging. Next slide. And you can click on the video, please. You'll see here us navigating into that left upper lobe lesion. Again, up in the screen, the bronchial tree with the anatomy border. In the lower screen, you'll see the target. You already saw the EBUS, the radial EBUS image, and you can also see the fluoroscopy and the biopsy performed. And as Dr. Foch was mentioning also, the screen tells you, you know, how far you are from the target and from the anatomy border. And you can see up there on the screen the different passes, biopsy passes, and that's the feature, the biopsy marker feature, and that will tell you. I mean, it's an indication for you to decide to go to different areas of the nodule. That's very helpful, actually. Next slide, please. Another case I want to share, this was a 68-year-old gentleman, also smoker, left lower lobe nodule of 19 per 18 millimeter, also hot on PEP with negative mediastinum. We decided to do robotic bronchoscopic sample of the left lower lobe and EBUS staging. Next slide. And the video. Yeah. Again, we have already navigated into the lesion. You see there all the information that these screens provide you. You know, the bronchial tree, the target, the virtual target, the radial EBUS, fluoroscopy image, everything simultaneously. And you see there the needle on fluoroscopy going into the lesion. This was an adenocarcinoma, and the stations 7 and 11 were all negative. All the other stations were less than 5 millimeters per EBUS. Next slide, please. And I would like to end my presentation with a case that truly achieved a linear approach for a patient from diagnosis to treatment. This is actually a unique case that was led by Dr. Janani Reisenauer from Mayo Clinic, Rochester. They had a patient, 68-year-old gentleman, never smoker, with an enlarging pulmonary nodule that was following an outside hospital until finally consulted Dr. Reisenauer, and the nodule was 16 per 12 millimeter in the right lower lobe. The patient also had a history of a melanoma on the right shoulder in 2011, and the nodule was hot on PET with an uptake of 16. Next slide. And so it was decided to do a robotic bronchoscopic biopsy. So first, because the patient wanted to make sure what it had. And so again, we are seeing, if you can click on the video. Yeah, again, we are seeing that the navigation phase here, where virtual bronchoscopy is seen in the bottom left of the screen, and shows the customized path, and a real-time bronchoscopy is seen on the bottom right. There is a constant feedback of distance, location, and pleural boundaries marked with the anatomy border that I mentioned to you. You see there the bronchial tree pictures with an overview of the bronchoscopy nodule and carina. And actually, in this case, they found an endoluminal component that confirmed the location of the lesion. You see there on the right airway. And when the bronchoscopy was close enough to the target, they performed radial EBUS to confirm the presence of the lesion. If you can click on the video again, please. Yeah. You see the radial EBUS there, confirmed the lesion, and then they did a biopsy with a 23-gauge needle, and that was positive for malignancy. So the patient was discharged home. This was done in the morning, was discharged home, and next day was admitted for robotic surgery for a robotic-assisted lobectomy. The initial examination, there was no evidence of pleural disease or pleural fluid. Then the bronchus was divided, and then the posterior parenchymal fissure was divided to complete the lobectomy, right lower lobe lobectomy. And then by using an endoscopic specimen bag that you will see there, the right lower lobe was removed. Next slide, please. So, you know, this case, again, they first approached it with robotic bronchoscopy because the patient wanted to know before undergo surgery. He prefers to try to confirm the diagnosis of malignancy. Next slide. And the histology for the bronchoscopy was the rows was consistent with apparently a non-small cell carcinoma, and we knew that the lymph nodes from mediastinal EBUS staging were negative. Next slide. So again, next day the patient was admitted for robotic-assisted lobectomy and mediastinal lymphadenectomy performed by Dr. Reisenauer, both procedures, the robotic bronchoscopy and the robotic-assisted lobectomy. Next slide. And the final pathology of the surgery was consistent with metastatic melanoma, and the immunohistochemistry confirmed that, and all the lymph nodes were negative. Next slide, please. So to finalize, in a patient with a lung nodule, instead of going through a variable pathway, next click, please, you can achieve a linear pathway, a more linear pathway, by performing the diagnosis with robotic-assisted bronchoscopy and treatment with robotic-assisted surgery, like in the case presented by Dr. Reisenauer. Thank you very much.
All right, everyone. Thank you. Again, we're open for questions. So please submit any questions that comes to your mind. I will kick off the question session with a couple of questions that came to my mind during this presentation. Very exciting development in the field of bronchoscopy. And thank you to Dr. Folk and Dr. Busey for sharing their experience and their cases. In terms of visualization, do you feel that this visualization is needed during your bronchoscopic procedures?
So I'll give you my opinion, then I'll let Dr. Fernandez-Busey comment. So visualization allows you to reach areas that are within the scope of the bronchus sign, right? If there's an airway leading there, it helps you to get there. With the ion system, you remove the camera and then introduce your biopsy tools and obtain the biopsies that way with needle or forceps. I particularly like better the needle in every instance, and it has yield very good results in other platforms and this platform. On the Auris Monarch platform, you have continued visualization at the time of biopsy. What I would pose out there is that after you obtain a biopsy under visualization, the same thing as with distal small bronchoscopy, when you use a small bronchoscope, is you get blood, and thereafter, all the subsequent biopsies or all the subsequent are really not done under very good visualization. And this is proven by the number of times that people have to come back and suction and re-navigate to the periphery under these visual-based platforms. So I think it's overrated. I think many of the nodules that we're targeting, both Dr. Fernandez-Busey and I and the other co-investigators, do not have a bronchus sign, and you get within striking distance of the needle, and you have to rely on the precision and the direction that you receive from the software. No?
Yeah, I agree with Dr. Foltz. But the message is, if you have a bronchus sign, then visualization is helpful. But again, the system does have visualization that will get you into to see that lesion at the beginning, and then you can start doing the biopsies. But again, after the first biopsy, then everything becomes bloody, and indeed it's not really helpful to have the visualization if you have a lesion outside the airway. So that's the key here, is that you would really like to make sure that you position your catheter close to the lesion, that you're really able to navigate to the lesion, to the target lesion, and then you have stability, and then nothing will move, and you can continue doing the biopsies.
That's very helpful. And in terms of a lot of the newer technologies, in terms of visualization modalities such as cone beam CT, what are your experience in terms of integrating the robotic bronchoscope with cone beam CT navigation bronchoscopy?
So the cone beam CT is a metallic object and it generates a ferromagnetic field, of course. And so any technology that is based on electromagnetic navigation will have a distortion related to it. However, two things. One is with the ion, with the shape sensing technology, you do not have that problem, and we can fully implement the use of cone beam CT for confirmation of location and consider even ablation technologies that are starting to come out in the US and that are available in Europe. In regards to the Monarch or system, it has this possible error with the use of the cone beam CT. However, my colleagues who have used this platform extensively have devised alternative changes or workarounds in order to be able to use it. But it definitely is something to be aware of. I wonder what Sebastian thinks.
Yeah, I do not have experience with cone beam CT, but I have heard, from Michael Pritchard that has a lot of experience combining ion and cone beam CT. That again, there's no problem because this is not an electromagnetic technology, and that he is very able and easily can integrate both technologies.
Okay, great. We have an audience question regarding specifically, is there any data out there that looked at ion, and how do you address the problem of CT to body divergence?
Sure. So CT to body divergence, so if anyone in the audience hasn't heard the term before, is what we call the changes or the delta between what we see on a fully inspired CAT scan, right, at the time that the patient took a full inspiration, got a CAT scan image, and what we see during bronchoscopy when the tidal volumes and the level of tension of the respiratory muscles is different. So this alters the location of structures in the chest, including the lung nodule you're targeting. So to address this, the most important thing is prevention, right? And every technology that we do under sedation or where the patient doesn't have a full inspiration will be victim to this, right? It doesn't matter what technology you use. So the best thing is to prevent it. What I use, and Sebastian will tell you what he uses, but what I use is first, I minimize the time that the patient is sedated without a positive pressure mechanical ventilation. So it's a rapid intubation. Second is right after intubation, we use an open lung ventilation in the sense of using 10 cc's per kilo, and we use a inspiratory breath hold to maintain alveolar inflation. The third thing I do is if I'm going to do endobronchial ultrasound sampling, I do it after the peripheral biopsy. And the reason is I do not want to cause atelectasis by suctioning or by occluding the airway or by generating bleeding in the airway that may cause atelectasis, which is the gravest form of CT to body divergence. So by doing all this, I minimize that. And the last thing is you can use a real-time technology such as radial EVAs or cone beam CT to correct for the few last millimeters if they exist. But Sebastian.
Yeah, I agree with Eric. The only thing that I can add to that, because we do exactly the same thing, but the only thing that I can add to that is right after intubation, we go in with a regular scope just to do an airway exam and clean up the airway. And right after that, and before we go in with the robot, we do a recruitment maneuver using 20 of PEEP for 20 to 30 seconds, to, as you mentioned, those atelectasis, to open everything very well, make sure everything is opened. And then we continue the ventilation with 10 of PEEP and 8 to 10 cc's per kilogram of ideal body weight. And we start sampling mainly, the problem is mainly here in the lower lobes. CT to body divergence is mainly in the lower lobe. And we start sampling the lesions, and if we are not getting an answer, then we start doing the breath holds on inspiration. And we always try to confirm by radial EBUS, of course, and all fluoroscopy. And if we can identify the lesion by radial EBUS and all fluoroscopy, we go with that information where the lesion is and continue biopsy guidance by that.
Okay, that's really helpful. So we have several other questions, but given the time constraints, we're gonna ask one additional question from the audience. That question is, what would you say about the key factors in terms of increase in the yield that you're getting from the bronchoscopic biopsy compared to other modalities? Can you distill the techniques or the experiences that you have to a few bulletin points for the audience?
Sebastian, do you want
to? Go ahead. So, George, was the question what kind of skills the bronchoscopist needs to have to perform this technology?
The question is, what are, in your opinion, what are the key factors that you perceive to increase the yield for peripheral nodule biopsy?
Oh well, the main thing of these robotic technologies is able to navigate to the nodule, then the stability that provides this, the distal articulation, then on this precise system, the biopsy markers, this allows you to mark each biopsy trajectory to the lesion, so you can modify it very finely where to do the biopsy in the lesion. So all those characteristics are the ones that increase the yield to compare to, of course, regular bronchoscopy, but also the other navigation techniques.
George, if I may add, the other part is, as we gain comfort with this advanced technology that allows you to reach the very periphery, you sort of develop also a three-dimensional picture in your mind. You look at the CAT scan different, you are looking for an airway that is nearby, and you look at the angle of attack of a needle. It feels a little like being an interventional radiologist, but being inside the chest, where you direct the needle in a certain angle to biopsy this nodule from the closest available airway. So when you look at the CAT scan after using the ion system, you always attempt a very careful review of what are the anatomic landmarks, at what level is this sagittal, coronal, axial, and you create a mental picture. And the system also tells you, once you're in the procedure, the system tells you the best angle of the fluoro machine. And this limits the artifacts in the field. And so sometimes when you could not see a small nodule, with the appropriate angling, now you're able to see the shadow of a very small nodule on the floor. So all of these things and the ability to add the radial levus and the fluoro make it a very reliable system. Now, I have to say, as you can see from the pictures we both showed and the cases we both showed, we find ourselves going after lung nodules that previously we would not have tried. And when you start going smaller and smaller, the probability of benign disease is higher. So some of the cases I've done, like the one I showed you, you end up biopsying and questioning, is this truly benign disease? And we've been very happy with the results of either confirmation studies or the actual placement of a fiducial for guiding radiation or surgery. No?
Yeah, that's fantastic. As a part of the training, typically when we sample the peripheral nodules, we go with needle, forceps, or a brush. We use a combination of tools. Is it accurate to assume that you also use combination tools, or is it just predominantly the needle?
We generally do use a combination of tools. But we generally start with a needle. I don't know, Eric, if you do the same, but we start with a needle for sure, and then we can sometimes, we start with a 23 gauge needle, and sometimes we choose to move to a 19 gauge needle if we're not getting enough tissue, and we may decide to also use the forceps. But yeah, most of the procedure we use a combination of tools.
In our case, I have to say, we start with a needle, just like Sebastian said. We start with a needle, we send the rows, and when I'm obtaining the second or third or fourth biopsy with a needle, I frequently get the results from rows and I stop there. But when the rows is taking longer, or when I need more tissue and more certainty, I certainly use a forceps. I have not used the brush yet because I haven't needed it, and but I have to say I'm very impressed with the performance and flexibility and durability of the peripheral needle.
That's fantastic. Okay, guys, so thank you to Dr. Folk and Dr. Fernandez-Bussy for your time and the exciting discussion. For our listeners, I hope you enjoyed this conversation, and we look forward to be here with you next time. Thank you again, everyone, for joining us.
Thank you.
Thank you.
All right, this concludes this webinar.